Now we know that if the meniscal root is torn, specifically the medial ones, it is equal to complete meniscectomy. And once the meniscal root is gone, like your complete meniscectomy, the medial joint will degenerate very, very fast in a span of 1 year. So we have to be very aggressive in diagnosing as well as treating this medial meniscus root tear. And we specifically see these sort of meniscal root tears in the middle-aged males and females, overweight females. So when they are coming to the OPD clinics, we have to diagnose very early. And we have to know the anatomy of the meniscal root attachments. If we read the Lapra's article where the medial meniscal root, where the lateral meniscal root is attached, we have to look for certain landmarks, specifically the medial eminence, the lateral eminence, the PCL, the white side fibers, and also we have to know the posterior margin. You have to see and feel during the arthroscopy the posterior margin of the tibial condyle so that we can place the jig properly. Nowadays, there are specific jigs available for the medial and lateral meniscal root repair so that we can bypass the eminences, so that we can see jig can be sit properly and the root tunnel can be created at the exact anatomical location. And Laplace has classified the meniscal root tears into 5 types. One is the type 1 is the partial radial tear, type 2 is the complete radial tear with 3 varieties from 0 to 3 mm, 3 mm to 6 mm, and 9 mm. Then type 3 is the complete radial tear with occipital extension. Type 4 is the oblique tear, and type 5 is the bony avulsal of the meniscal root. Few facts that we have to remember is the root tears are nearly 10% when we do the scopy for the young people. Lateral meniscal root tears is 10 times more than medial meniscus. And even in the MRI, we can miss the lateral meniscus root tear. Suspect lateral meniscus root tear in grade 3 or pivot or the Lachman because roots really gives us extra stability. And medial meniscus root tear is common in middle-aged females, specifically the overweights, and it is usually degenerate. And when you see the study, the MRI pictures, if we see the sagittal cards, this is the classic ghost sign. You can see the anterior horn, the triangular part, but there is nothing is there present. You can see, if you see the yellow arrow, this is the classic ghost sign. And also in the axial picture, we can see that there is a gap in the root, posterior meniscus. Also in the coronal cards, we can see the gap here in the posterior meniscus root. And now we can see this is the coronal cards, where if we see the, if we draw a line from the medial femoral surface to the tibial condyle, you can see the meniscal extrusion. So the meniscal extrusion is a classic signal, and we have to be very cautious in seeing the MRI pictures whether we are going to miss the meniscal root tears. And the medial meniscus root tear, as I told you, it is a silent epidemic, because you see if you go you see the X-ray from left to right, within a span of 1 year time, the whole medial compartment, you see the gap has been completely been reduced. It is now bone touching the bone on the other side. So medial meniscus root tears are really notorious for early degenerative changes. And this is the picture how we reattach the medial meniscus root. We have to take bites, 2 bites at the root. Then we create the tunnel. And then the sutures or the tapes can be tied on the medial surface, either with the endo button or a round button, or we can tie the sutures on a bony bridge. When we work on the medial meniscus root, really the space is less. So we have to bypass the medial collateral ligament, and this is the magic point which Dr. Banta has told us, that if we draw the superior surface or the medial surface of the tibial condyle here and draw the posterior border of the tibia, then this magic point is 1.2 centimeter above the tibial joint line, and it is 1.8 centimeter distal to the medial epicondyle. This is the Pancha's magic point, where he has told that if you just do one puncture, you can release the compartment. But usually, when we do see, we do 5 to 7 punctures or even 10 punctures to see. If you see, this is the root. The root has been torn from that side, and you can see already that there is degenerative changes on the femoral side. So we have to be seeing whether the root is torn or not, where it is reducing, and then sometimes we have to release the capsule to make it reduce at its anatomical location. And this is the pie crusting technique, where we can do 7-8 punctures of the MCL, putting the valgus stress, so that we release the medial compartment and we can work on the medial side, because sometimes in the degenerative, the medial side is really tight. Now you see, we have created the crater, where the meniscal root can be reattached, and we can see with the probe that it can be reduced at the crater. Now we have taken the bite. See, we have taken 2 bites and we have done the drill, and now it has been reduced on the crater. So this can be tied with the button at the front, or on the bony bridge, or with the round button. Now this is another one with the tape. You can see we have reduced the medial root. This is another one. The specific key is available, where we can bypass the medial eminence. We can see the posterior extent of the tibial condyle, and we can locate the key at the proper place. So we have to remember, when we do repair the medial meniscus root, we have to bypass the MCL to get the working space. We have to see the classic anatomical location of the root, because you cannot reduce its non-anatomical position. Then we have to freshen the peripheral rim, whether it can be reduced at the anatomical location. We have to create the crater, and then we have to drill the tunnel to reattach the meniscal root. And we can use the fiber tapes 2O, or we can use the fiber wires, 2 bites, and then we can tie it on the front, on the endo button, round button, or the bony bridge. So remember that whenever we get the grade 3 pivot, we have to read the MRI very carefully. And when we do the scopy, look for it, probe for it. And 3 basic things we have to follow: A, B, C. One is the anatomy. That means we have to do the anatomical reduction of the meniscal root. B is the biology. That means we have to create the crater. We have to do some punctures at the capsule, or we have to release the capsule. And C is the compression. That means you have to reduce the root at your crater. Thank you very much.